Well, hey, everybody, this is Robert, and welcome to the show. Now, in a recent Morbidity and Mortality Weekly Report, or the MMWR, experts from the CDC produced updated recommendations for the human treatment and prophylaxis of plague. So, joining me today to discuss plague and the updated recommendations is Christina Nelson, MD. Dr. Nelson is with the Division of Vector-Borne Diseases, the National Center for Emerging and Zoonotic Infectious Diseases at the CDC, and she served as the co-chair for the steering committee and plague clinical guidelines team. Dr. Nelson, welcome to the show, ma'am.
Thank you so much. Thanks for having me. It's a pleasure.
You bet. I want to go ahead and start off the conversation on the disease and the bacterium. Can you talk about the causative agent of plague?
Sure. So plague is caused by a bacteria called Yersinia pestis. It is a gram-negative bacteria, which means it stains a certain way with a gram stain and kind of is in that large category of gram-negative bacteria. And it's a coxobacillus, which means it kind of has this short rod shape or an oval shape on various stains. And it has what's called bipolar staining. So these are all things that help identify a bacteria under a microscope. That means the stain kind of concentrates on either side of the bacteria. And that's helpful information because it gives it a very characteristic, what's called a safety pin appearance under the microscope with certain stains like Wright and Giemsa stain. So sometimes that's actually the very first indication that a patient has plague. They might take, the clinicians might take a blood sample, stain it in certain ways and look at it under the microscope and see that safety pin look and think to themselves, this might be Yersinia pestis and this patient might have plague. This bacteria persists in the environment, so it kind of maintains itself in cycles called zoonotic cycles. So it kind of jumps between various rodents and other animals and fleas, stays there at a low level, and then every once in a while it sort of blows up and becomes an epizootic and causes lots of die-offs of animals. You can see die-offs of prairie dogs and voles and other things related to plague. So that, and then sometimes it can jump to humans, which is, when you hear about plague, usually when there are human cases. And there are other bacteria in the Yersinia family. The most common one is Yersinia enterocolitica, but that causes gastrointestinal infections. It's in the same family, but it causes very different disease.
Okay, great. So how do people typically contract this bacterium?
So most commonly, people contract the infection through a flea bite. So as I mentioned, the bacteria kind of maintains itself in the natural environment, but can jump to humans. And often what happens is the fleas will bite an infected mammal, acquire that bacteria, and then go on and bite a human. And the bacteria is transmitted to the human through that bite. Like I said, that's the most common. And so, for example, a flea could bite an infected prairie dog or an infected dog or cat, and then bite the human. The infection's transmitted through the skin that way and makes the human sick. Plague can also, or the bacteria, Yersinia pestis, can also be transmitted by direct contact. So for example, we see this sometimes in hunters or in kids who have touched a dead animal. If they have a break in the skin and they're skinning the animal or handling the animal other ways, the bacteria can be transmitted that way. And then through inhalation is probably the most dangerous way. People can inhale the bacteria from a sick cat or a sick dog or other sick people. So we can talk about that a little bit, that when people get the plague pneumonia or pneumonic plague, they cough up bacteria and can transmit the infection to other people. There was a case several years ago in Colorado of a dog who became very ill and was put down, and they didn't know what the dog had at the time, but then the dog's owner, the dog was coughing and very lethargic, was put down, as I mentioned. The owner ended up getting sick and had plague, and he contracted it by inhaling the plague bacteria from the dog. And then there's other less common ways to contract the infection. Ingestion. There have been outbreaks of plague. For example, there's an outbreak in Jordan several years ago related to eating infected camel meat. And then there's other less common ways people can get sick, but those are the most common ways.
Perfect. And plague really presents itself in a number of ways, different clinical presentations. Can you go over each of those briefly?
Yeah, that's a good question. So the clinical presentation really relates to how the person was infected. Kind of what we say is the route of inoculation. So how the bacteria entered into that human. So bubonic plague is by far the most common form of plague, and that comes from, most people have heard of bubonic plague and a bubo. So the bacteria enters through the skin, either through direct inoculation, handling an infected carcass, for example, or the flea bite. It travels through the lymph system and infects a lymph node and starts to multiply there. And that enlarged, painful lymph node is called a bubo. It's often so painful that patients don't want to move, and it's very enlarged, and often is the first clue that a patient might have plague. If the patient's not treated at that point, then the bacteria can continue to multiply and spread through the blood and spread to the lungs and other places. So again, that's the most common, bubonic plague, with that very painful enlarged bubo. Pneumonic plague is also a form that I mentioned. So if people inhale the bacteria, they get sick quite soon after that. Within a day or two, they get fevers, they start to have trouble breathing, coughing, feeling very low energy. And then as the disease progresses in the lungs, they start coughing up more and more. They start coughing up blood and lots of bacteria, and eventually have respiratory distress and often die from that. And then the other most common form is septicemic plague, which is a bit of an enigma. That is when there's no localizing signs. So a patient's sick, they have the bacteria in their blood, but there's no bubo and there's no evidence of pneumonia, or no obvious evidence of pneumonia. And so that's, again, what we call septicemic plague, which really just describes a patient who is sick, has a bacteria in their blood, and is septic, but does not have a bubo that we are aware of, that the clinician's aware of. I will say we're doing some research right now, putting together cases on what we call occult buboes. And so some cases that look like septicemic plague, the clinicians might think that they have appendicitis, for example, because they're complaining of abdominal pain, they have fevers. They take them to the OR and start surgery, and lo and behold, they actually find a bubo, for example, in the abdominal cavity. So some patients who have been diagnosed with septicemic plague actually have a bubo. It's just not apparent readily on physical exam. It's kind of hidden. So we're looking more into that, but those are the main forms. Some less common forms, plague meningitis can occur. So that's usually a later complication of another form of plague, but Yersinia pestis can infect the meninges, kind of the covering of the brain, and cause headache and fever and vomiting and seizures. And also other less common forms, ocular plague. So if someone gets the bacteria on their hands and maybe touches their eye, they can get an infection there. Pharyngeal plague also can happen after ingestion of the bacteria. So these are much less common, but also worth mentioning.
Okay. Well, Yersinia pestis is treatable with antibiotics. Is most untreated plague fatal? What do we know
Yeah.
about that? Yeah.
Yeah, so again, it depends on the form again. And yes, very good point. That's something that we really want to help educate others and share, that plague is treatable with antibiotics, and antibiotics that can be readily obtained usually. But it's really important to get those antibiotics on board early in the course of disease, kind of recognize that the patient has plague and then get the antibiotics on board early. That's when patients have the best outcomes. So untreated bubonic plague is about 60% fatal. So high fatality rates, but some patients actually can survive if untreated and they had bubonic plague. On the other hand, for pneumonic and septicemic plague, the fatality rates are much higher, over 90%. So someone who has pneumonic plague who is not treated with antibiotics has almost zero chance of surviving. There are a few cases, but it's nearly always fatal, unfortunately.
So, Dr. Nelson, so where do we see most of the naturally occurring plague on the planet?
Yeah,
People.
so plague, yeah, and that's a good point. Plague still occurs. You know, a lot of people have heard of plague as it relates to history, the Black Death, and other epidemics of plague. But plague still happens naturally around the world, and it's still a threat. So most cases occur in Africa these days. Madagascar has the most cases in Africa usually, and had a large outbreak in 2017. They've had some recent cases of bubonic plague as well. Also in the Democratic Republic of Congo, they have had recent cases, and you might have reported on that as part
Many
of your
times.
system, yeah. And also in Uganda. So those are kind of the most common places in Africa. Plague can also occur in South America, most commonly Peru. Bolivia has some cases sometimes as well. Peru had a very tragic outbreak in 2010. A patient came in with pneumonic plague, and a medical student and a medical resident who were seeing that patient ended up contracting pneumonic plague from that patient, and the medical student ended up dying. So that was kind of a very tragic cluster of cases. And plague also still occurs in parts of Asia. In China, Mongolia, Russia still report cases. And then last but not least, plague still occurs in the United States, in the western states, most commonly New Mexico, Arizona. We also see plague in Colorado, California. So it still occurs often in the summer months, but can occur outside of the summer months as well.
All right. Well, the plague bacterium Yersinia pestis is a tier 1 bioterrorism select agent. Dr. Nelson, can you talk about Yersinia as pestis as a potential biological weapon?
Sure. Yeah. So tier 1 select agent is basically the highest risk category of bioterrorism agents. And the reason Yersinia pestis is in that category, number one, it's been used historically as a bioweapon, which I'll talk about in a little bit. But there are various kind of factors related to that designation. So number one, plague or Yersinia pestis can be kind of put in a powder format and released into the air. And so that could potentially infect a large number of people, and that would infect people through the lungs, causing pneumonic plague, which is, of course, the most rapidly infectious and has a very high fatality rate, especially if it's not treated early on. So it can cause severe disease. It can be released into the air and infect large numbers of people. And also there's the potential for person-to-person transmission. So after an intentional release of Yersinia pestis, the infections could be propagated from one person to another. Now, the rates of person-to-person transmission are not high. So usually it happens when someone is very sick, coughing up a lot of the Yersinia pestis bacteria, and others are very close to that person, and then they become infected. So it's not highly common that person-to-person transmission occurs, but it can occur, and again, propagate an outbreak following an intentional release. So, so those are some of the reasons it's designated as a tier 1 bioterrorism agent. As I mentioned, it has been used in history also as a bioterrorism agent. So hundreds of years ago, back in 1346, there was a siege of a city called Kaffa, which is now named by a different city and in Ukraine. But the Tartar army actually had kind of a wave of infections and people die of plague. And they were attacking the city, and they used catapults to hurl those corpses into the city. That caused infections in the people who were kind of locked down in that city and under attack. So they lost lives that way. And then people also fled and spread the infection to other parts of the country and around the world, potentially. Also, Yersinia pestis was used during World War II by a unit of the Japanese Army called Unit 731, and they did a lot of research and other activities related to bioweapons. And so they actually dropped plague-infected fleas over certain parts of China. There's not a lot of good information about how many people were infected in those areas of China as a result of the attack, but it's believed that hundreds to thousands of people contracted plague as a result of that. And then more recently, during the Cold War in the 70s and 80s, it's been reported and corroborated that the USSR developed Yersinia pestis in large quantities for use as a bioweapon. And also there have been more recent examples in the past decade of individuals or terrorist groups who have shown interest in Yersinia pestis as a bioweapon. So it continues to be a threat, and that's why it's important for us to be prepared for it.
Let's go ahead and switch gears to the treatment and prophylaxis guidelines. And there they are in the MMWR about a month ago. And Dr. Nelson, what was the rationale for the guidelines and how did your team go about it?
Yeah, so the rationale, first of all, the most recent guidelines before these were published were released in 2001. So the guidelines were, 20 years old, and since then, they were very comprehensive guidelines and very useful for many years. But since the publication in 2001, there's been new data, there's been new animal data and new human data, and the FDA has actually approved indications for treatment of plague, new antibiotics. So ciprofloxacin, moxifloxacin, and levofloxacin all have been approved for use for treatment and prophylaxis of plague since the publication of those previous guidelines. So there were a lot of updates that kind of needed to be taken into consideration. Also, the 21st Century Cures Act actually mandates that if medical countermeasures, and so those are things like antibiotics, vaccines, antitoxins that are stockpiled in the Strategic National Stockpile. We've heard of the National Stockpile a lot in the news lately related to COVID. There's ventilators and personal protective equipment, and there's also antibiotics and other things to treat and prophylax against bioweapons. So the 21st Century Cures Act actually mandates if things are stockpiled, then we need to have updated evidence-based guidelines in order to use those medical countermeasures. And so the time was right, and it was important to update these guidelines. What we did is we wanted to make sure that the guidelines were based on the latest evidence and the most comprehensive evidence. And so for development of these guidelines, the process really started with a systematic literature review. And so we spent a lot of time collecting all the publications we could find, translating from many other languages, putting together all that evidence, any published case of a patient who had plague, was treated with antibiotics, and then was reported in the literature. We put those together and analyzed the outcomes, which patients did better based on which antibiotics they received. We also analyzed U.S. surveillance data of plague. So plague is a nationally notifiable condition. And so when it occurs, state and local health departments report the disease along with other information, how the patient did, what treatments they received. All of that information is reported to CDC for a variety of reasons, and we use it in different ways. But we had all this excellent data that we could rely on and summarize and look at the antibiotics that way too, to see what's the evidence behind the effectiveness of these various options. Once we gathered all that information, we brought together an expert forum. And so we brought various experts on plague and infectious diseases and preparedness and neonatology and obstetrics and gynecology, lots of experts from all around the world to talk through. We collected individual input from these people who attended the expert forum, talked through the recommendations that CDC is planning on, advantages, disadvantages, what are the considerations, and we really kind of collected a lot of input from these experts to help us consider what's the best way forward for these guidelines. So after bringing together all of those experts, we again looked at the data, put our heads together, and came up with these recommendations that were based on the evidence that we had and expert opinions.
So if we were to put up a couple of headlines of the biggest changes compared to 2000, what would those be?
Yeah, that's a great question. So lots of important changes. So I think one of the most important ones is that ciprofloxacin, levofloxacin, and moxifloxacin are all now first line.
Mhm.
So they're basically the one of the preferred medications, both for treatment and prophylaxis of plague. And that's really helpful because these medications have good oral bioavailability. So if someone can take a pill, then the medication will get into their blood system well. They don't necessarily need to be given IV or intravenously. And they are medications that, are readily available usually, and can be taken by a lot of people. So that really kind of expands options, which is great. We also included a lot of within class alternatives for antibiotics. And so, for example, if we had an aminoglycoside, for example, gentamicin is an aminoglycoside antibiotic that is a first line. We also included alternatives in the same class, so in the aminoglycoside class of antibiotics, as recommended kind of alternative or second line antibiotics. So we really wanted to offer a lot of options. If there were a large outbreak, we're going to need as many options as possible to treat and prophylax as many people as we can. So those are some main changes. Also, Bactrim is a sulfa drug. It's trimethoprim sulfamethoxazole. And that has been used for many years for treatment and prophylaxis of plague. And based on the evidence, we felt that it was a good option. And so that's included as an alternative both for treatment and prophylaxis. So really expanding options and using the evidence to put together the best recommendations and the antimicrobials that are most effective for plague.
Yeah. Now, a few moments ago, you did talk about the different forms of plague. Are the treatment regimens different for each different form?
That's a good question too. So the answer to that is yes. So for pneumonic and septicemic plague, that was what we focused on initially, and that was our first table in the publication, primarily because if an intentional release of Yersinia pestis were to occur, most likely it would be by the aerosol route, and people would inhale it and have pneumonic plague, develop pneumonic plague. And so for that, there are certain antibiotics that are recommended, but doxycycline, in the previous guidelines, doxycycline was an alternative. It was not a first line. And we actually kept it that way for pneumonic plague and septicemic plague. We do think it's an effective antibiotic for plague, absolutely. But there are some indications, for example, from animal data that's been published, that it may not be quite as effective as the other antimicrobials like ciprofloxacin. Again, still a great drug for plague. The animal studies that we were looking at may also have been affected by other issues, for example, delivery of the medication, and other things that are still being worked out. So, but for now, what we did is we left doxycycline as an alternative for pneumonic and septicemic plague. However, moving on to bubonic plague, doxycycline has been used for decades for bubonic plague. It's very effective, and so doxycycline is actually a first-line treatment for bubonic plague. Those are the main differences.
Yeah. What about those special patients, those with special situations, say pregnant women, young children? Is there any special treatment guidelines for them?
Yeah, so we really wanted to make sure we included a variety of populations. Naturally occurring disease. So these recommendations cover both naturally occurring disease and an outbreak following a bioterrorism attack. Those populations can be affected just like anyone else. And so we really wanted to make sure we considered the evidence, and really thought about, for these populations, would the recommendations change? We really want to make sure that we're protecting the patient and giving them the best antimicrobial for what they have and for their situation. So there were recommendations in the previous guidelines for pregnant women, and so we built upon that. For pregnant women, actually, we recommend that for naturally occurring and bioterrorism-related plague, pregnant women get a combination of two antibiotics. So they get gentamicin plus either ciprofloxacin or levofloxacin.
Mhm.
So two antibiotics, two different classes, and that was felt to be the best based on pharmacokinetics, and what pregnant women can tolerate and what are the best medications in that population. But really an important point is, for pregnant women, you really need to save the pregnant woman. There are always risks and benefits, and you want to consider the risk to the fetus. But the most important consideration is protecting, either treating or prophylaxing the pregnant woman. And if you have multiple choices that are of equal effectiveness, then you can start balancing, which one is safer for the fetus. But really important just to get those medications on board and save the pregnant woman's life. But we also added, what's really exciting about these recommendations is we added other special populations. So we have recommendations for breastfeeding infants, for neonates, for the elderly, immunocompromised, and other populations. So we wanted to really give clinicians the information we had and what we thought would be appropriate for those populations also.
Yeah. Did you come across any limitations to the work that you guys did?
Yeah, so I think one of the main limitations for the guidelines is that, we gathered as much evidence as we could, and we really were very meticulous about finding all of the evidence that we could. And so I'm really proud of how much evidence we were able to collect, and I think that really helped inform the guidelines. However, with plague and other diseases that are sporadic, it's hard to collect, to do studies and collect solid evidence on efficacy of treatment. Randomized controlled trials, as you probably know, are the gold standard for looking at antibiotics and other treatments for a condition. And so, you might get a group of people, randomize them to receive one antibiotic versus another, and then see how they do once they contract the disease. For plague, that's hard to do for many reasons. It's a very sporadic disease, so outbreaks will pop up, and you can't necessarily start the randomized trial, as soon as the outbreak is popping up. And also, you want to make sure that that you are conducting ethical studies, so you can't withhold treatment. You would want to make sure that if you're doing a randomized controlled trial, you're comparing to antibiotics or to other treatments that you think are effective. So it's very hard to collect that gold standard data. So we had to rely on case series and case reports. There's a group of patients or one patient who develops plague, gets a treatment, and then is published in the literature or reported to CDC. And so that information is valuable. That's good data to have, especially when you combine it and look at it as a whole. But it's not as robust as randomized controlled trial data. But we used the best that we could. Like I said, we gathered a lot of evidence, and so we think that we were able to have kind of a solid evidence base given those limitations for the guidelines. What else I will say for limitations to the guidelines is this is not a living document, and so it is current now. Things can change, but this particular document is static, so cannot be changed. So if we got new information or if there were a bioterrorist attack, that document would still be definitely useful. But if there were changes, updates related to data or related to a specific bioterrorist attack, there are other ways we could share that information. Of course, we could put information on CDC website and other things, but this particular guideline is not a living document as it stands. So that's another limitation that people have to keep in mind, to look for other information if new data becomes available. And we will update them as needed. If we need to do kind of a full comprehensive update, we will make sure to do that.
Okay. And let me go ahead and just close with this. Give you the floor. Any final thoughts on plague, the guidelines, anything else on your mind?
Yeah. So final thoughts, I really do want to share, as we discussed, that plague still happens. We've had cases this year in the United States, including one fatal case. And so if a patient comes in very sick and a patient has symptoms that could be compatible with plague and an exposure history that could be compatible with plague, it's important for healthcare providers to think of that and get antibiotics on board, even as you're suspecting it, and then you can confirm the diagnosis later. And it also occurs around the world. So, there are still cases occurring. There are still people dying from plague. And so we need to be vigilant and make sure that people can get the appropriate treatment and prophylaxis. I also wanted to mention that there is currently no vaccine against plague available in the United States. There have been vaccines available in the past, for example, for members of the military and others. It did not seem to protect well against pneumonic plague, which of course is the most dangerous and the it has the highest case fatality rates. So it has not been available recently. But in the recent news, actually, it sounds like the Oxford Vaccine Group is starting a phase 1 clinical trial of the plague vaccine. So we're not involved with that. It sounds like it's the same platform as the AstraZeneca Oxford COVID vaccine. And so they're kind of using that platform for other purposes. But it's exciting, and it will be interesting to see what they find.
All right, good stuff. Well, again, the MMWR, antimicrobial treatment and prophylaxis of plague, recommendations for naturally acquired infections and bioterrorism response. And I'll go ahead and link to this in the show notes when I publish the podcast. And I want to thank you, Dr. Christina Nelson, for your time and your expertise. Appreciate it, ma'am.
Thank you so much. Thanks again for having me.